that yet.
Okay. I've downloaded it. Then how do we do next? What do we do?
Then you have to go on to the video.
You have to go to the where you have your video. There you have a small arrow. Choose virtual background.
There I have my video.
Stop video.
Stop video. Next to the stop
arrow.
video, there is an arrow there.
Yeah, so just click on that. It will give you that.
It will give you choose virtual background.
Stop video. Okay. Choose virtual background.
Right. Bhavesh, can you remind Asha Lata to join?
I'll do that.
So, Mamta, Amit, and Jayanthi, I'm your host today.
Oh, excellent.
Yeah. And I would be putting up some of the questions one by one to the individual. And you need to give the answer. Mamta, you can answer some of the questions in Hindi if you wish.
Oh, yes, I'll answer as many as I can in Hindi. This is for patients, right?
Yes.
Yeah.
But this goes to all over India. Not everything.
Most people do understand Hindi, don't they?
Yeah, but we should keep it English as well as some.
So just a second. So when you say you want to use a virtual background, but my screen is downloaded, but there is no option about, download. How do I select it now? Bhavesh?
Ma'am, have you already downloaded that on your local device? In the email, there was an attachment.
I have downloaded it just now, yeah.
Now, when you go to that next to the stop video, there is an arrow.
Yeah.
You click on that arrow.
So, Nirmal, I have to just introduce Chatrabhuj.
Then there is
video karo, to uske baad choose virtual background, click karo.
Right.
Then it opens a screen where general video, audio.
You introduce all the speakers.
Ma'am, वहाँ आपको एक
they have the PowerPoint
option आएगा.
क्या option?
Virtual backgrounds.
Virtual background.
वहाँ पे उसके line में ही there is a plus sign there.
अच्छा.
To the right.
Choose virtual background करो तो वो background and filters पे जाए.
Correct. Video filters से और भी right पे जाएंगे आप. Video where you get your video at the bottom right of that. There is a plus.
Yeah. Got it. So all my files will be. Has it got chosen?
So, Sangeeta, you introduce all the speaker and moderator and then hand over to me. I think Mesham is not there. Otherwise, as soon as Mesham joins.
Bhavesh will be showing PowerPoints of each one. Their intro slide.
Ma'am, we don't have all the PPTs.
Okay, so I just introduce.
Bhavesh, please ask Meshram and Asha Lata to join. Asha Lata,
I'm just calling her only. She's not answered. I'll just try again.
भावेश क्या हो रहा है? मेरे को तो मेरी शक्ल पर्पल दिख रही है और बैकग्राउंड तो दिख नहीं रहा है.
Your face has changed now.
I'm all purple and I can see my home inside in the back. ये कैसे कर रहा है?
Ma'am, behind you, if there is a flat surface, then it will come out well.
Okay, so let me then. Okay.
I think now you're okay. You come out.
Come out of the purple.
Yeah, purple. Yeah. At least you come out of the purple. I think let it be how.
Bhavesh, we need to open the room now. 6:30 already.
I'll just open it.
Oh my God, my house doesn't have any flat.
So, we are live on YouTube.
Oh my God.
Perfect. Yeah. Perfect.
I'll have to do with this.
Yeah. So Ashalata is in attendee, so can you take her into the Bhavesh?
Just doing that.
Why Meshram has not joined?
And what about Sita? Is she joined?
Sita is not there.
Okay.
Chaturbhuj is there and Asha and Amit Haldar is there.
Okay.
Madam, no need to introduce me. I am just a spectator.
No, I have to.
Arey wah. Kyo?
I am spectacle.
It's 6:33. I think we need to get started.
Yeah, we're just waiting for people to join.
Okay.
Few more minutes.
Okay.
I'm in the panel.
Are you there? Okay.
I have already joined, but Gagan is starting the session.
So Gagan will start the session and you can introduce the chairperson and then Sangeeta can introduce the panel.
Okay.
So we start in another 2 minutes. Let Gagan join.
Hello, good evening, everyone.
Good evening, sir. Good evening.
Yeah.
Dr. Meshram, I think you start today's program now.
Okay, we'll start.
And let chairperson take over. Yeah.
So you will, after I start, you will say a few words?
I can say, yeah.
Okay. Okay, good evening, everyone.
Yeah.
Today we have a Purple Day and Indian Academy of Neurology has organized a public awareness program on epilepsy on this Purple Day. So I extend my best wishes on the occasion of Purple Day to all those people who are suffering from epilepsy, their caregivers, relatives, friends. And this Purple Day is very important to raise the awareness about epilepsy. We have, as usual, the Indian Academy of Neurology has organized this program. And we have very interesting and experienced panelists. We have Dr. Nirmal Surya, President of Indian Academy of Neurology. And to start this session, I request Dr. Nirmal Surya to say a few words as an inaugural address to this Purple Day program. I welcome you all for this session. I also welcome the chairperson, Dr. Sangeeta Rawat, who is chairperson of Epilepsy Subsection, Dr. Chaturbhuj Rathod, who is convener of the Epilepsy Subsection, and I welcome Dr. Nirmal Surya, who is president of Indian Academy of Neurology, and the panelists, Dr. Mamta Bhushan Singh, Dr. Ashalata, Dr. Amit Haldar, and Dr. Jayanthi Mani. So we are going to have a very interesting session. And now I request Dr. Nirmal Surya to say a few words. Dr. Nirmal Surya, please.
Thank you, Dr. Meshram. You have been a national coordinator for public awareness program and a very busy person because every other day you have some or other program to be done. Today is Purple Day and you know why Purple Day and what it is significant. So I'm sure my panelists will speak, but I just want to tell you that the Purple Day was started by Cassidy Megan, who is a a patient with epilepsy from Canada, Helsinki. It was very fortunate that she was in India. I have invited her in 2018, and in 2018 she has done a program in Mumbai, and she interacted, and then she has gone into the 4 other places, Ludhiana, Indore, and Chennai, and she is very popular among everything because at age of 9 years she thought of starting a awareness campaign, and that's the reason purple is the color of epilepsy. Today, on the occasion of Purple Day, the Mumbai will see Bandra Worli ceiling turn purple, and I'm sure that similar programs are happening everywhere. Today morning, we had sessions started from yesterday. Yesterday there was a session from BHU, which was regionally telecast all across the UP. Today morning we had a session. Afternoon we had another session from Bengaluru. There was another program of releasing the special message for epilepsy from Jaipur. Dr. Bhavna Sharma has done that. So we had similar programs been happening all over the India. And this is the main IEN program where we are going to talk to the people. Please log on to IEN YouTube, because you can not only know about the epilepsy, but there are series of new programs which keeps on coming, and you can get a notification to be present in all these programs. With that note, I thank Dr. Meshram for taking this forward. As president, I'm very happy, and I welcome all the panelists today. Today, the task of moderator has been handed over to me because everyone is busy across the country to create awareness on epilepsy. So thank you, Chandrasekhar. Back to you to take it forward.
Thank you, Dr. Nirmal Surya. And I would like to congratulate you for the Kenneth Wiste Patient Advocate of the Year Award. This award is given by American Academy of Neurology, and this year our IN President, Dr. Nirmal Surya, is selected for this award. So heartiest congratulations to you.
Heartiest
Thank you.
congratulations.
Thank you.
Well deserved.
Well deserved award. And now I hand over to Chairperson of the Epilepsy Association, Dr. Sangeeta Rawat.
Good evening to all, and I wish all the epilepsy patients a happy Purple Day. And I really congratulate Dr. Meshram and Dr. Surya and thank them for organizing so many events regularly for the public awareness. I think we never had in the past had so many public awareness programs. And after Nirmal has become a president, he has make sure that all the important events and days we have a public awareness program also. So today we have one more, and now I and Dr. Chaturbuj are we have formed the epilepsy subsection, which is a part of Indian Academy of Neurology. So under that auspices, we have today very eminent panelists who are working on the epilepsy day in and out. So first we have Dr. Asha Lata, who is an epileptologist and a neurologist from Sri Chitra. And she's very, very famous in her work of, epilepsy surgery, and plenty of articles she has around this. Then we have Dr. Mamta Bhushan Singh, who is very, very famous for her, the epilepsy, on the train, which is the project which she takes over in different parts of the world. Different parts of India, and she conducts the epilepsy camps through the train at various far and remote areas of in India. She's a professor at AIMS, and I think you are doing a wonderful job, Mamta. Then we have Dr. Jayanthi Mani. She's from Mumbai, from Kokilaben Hospital. She's very well known for her epilepsy work and also in epilepsy surgery work. And she has many published articles, and she has already got a 2 years fellowship from Cleveland Clinic. And then we have fourth one from the East, Dr. Amit Haldar, who is also an epileptologist in Kolkata. And he has also been trained in epilepsy at Great Ormond Street. So I think Nirmal is going to ask the questions. And my convener is Dr. Chaturbuj Rathod, who is from Baroda, and he's also very well trained in epilepsy. And we together are planning many more programs under the epilepsy subsection with good backing from I think Nirmal, Dr. Meshram, and a whole team of IN. So over to Nirmal for the further proceedings. Thank you very much.
Thank you very much. May I request everybody to keep their mic on mute, so whenever I ask the question, that person can open his mic and unmute his mic and speak. So now the question is, who should be the opening batsman? And obviously today the IPL is happening in Mumbai, so Mumbai takes the lead, and I'm from Mumbai. So the Epilepsy Purple Day opening batsman would be the Jayanthi Mani from Mumbai. So Jayanthi, the biggest question comes is, everybody here may know about epilepsy, but there are many more who doesn't know about epilepsy. So can you tell briefly what is epilepsy ultimately, what it is?
Sure, Dr. Surya. Thank you for this opportunity, and I really take it as a mission to spread awareness about epilepsy, and I'm really happy that you have me here today. So epilepsy is really a brain disorder. As many people may be aware that normally also our brain runs and functions because we have electricity running in the brain all the time. But the beauty is it runs in a very synchronized and controlled manner. And when for a few seconds or for a minute or so, when this currents in the brain become disorganized, almost like a short circuit, and then there is an explosion of extra electrical activity, that time the person's behavior becomes a little odd or different, and that constitutes what we call an epileptic seizure or a fit, जिसको हम हिंदी में दौरा कहते हैं या मराठी में आकड़ी कहते हैं, इसको हम fit कहते हैं. And when this fits or seizures keep happening again and again, one fit does not make it epilepsy. Anybody can have one fit if there's some disturbance in the brain, like there's high fever, or if the sodium goes low, or if the body sugar levels go low, you can have one seizure. So one fit or seizure does not make it epilepsy. Only if these fits happen again and again, and sometimes even without a clear immediate reason, then we say that that person has epilepsy.
Mamta, Mumbai goes to Delhi, and may I ask you a very simple thing? Why there is so much myths and taboo about this disease? There is a current in the brain or whatever electric activity, but why there are so much myth and taboo about epilepsy? There are so many other diseases which has got no taboo and myth. So can you explain to all of us?
तो अगर आप धन्यवाद डॉक्टर निर्मल सूर्या, एंड इट्स वेरी नाइस टू बी हियर विद ऑल ऑफ यू. और आपने जैसे कि कहा कि हिंदी में भी हम लोग कुछ बात कर सकते हैं, जिससे कि अगर ये यूट्यूब में वीडियो मरीज देखें तो उनको भी सही से समझ में आए. तो इस मिर्गी के रोग के इर्द गिर्द इतना आपने पूछा कि मिथ्स और टैबू यानी कि गलत धारणाएं, या इससे टैबू यानी कि इससे जो है इसके बारे में जो गलत धारणा है कि ये छूत की बीमारी हो सकती है, भूत प्रेत का असर हो सकता है, या हमारे पिछले जन्म के बुरे कर्मों का असर हो सकता है, इत्यादि इत्यादि. तो लोग अलग अलग चीजें सोचते हैं. तो ऐसा मिर्गी के साथ ही क्यों है, आपका ये पूछना है.
Yes,
तो हाँ, तो देखिए मिर्गी मेरे ख्याल से, क्योंकि जब तक जैसे डॉक्टर जयंती ने बहुत साधारण भाषा में समझाया कि ये इलेक्ट्रिकल करंट का बढ़ना घटना जो है उसके वजह से ये दौरे पड़ रहे हैं, परंतु आम मरीज क्या देखता है कि अचानक एकदम भला आदमी जो है एकदम ठीक ठाक अपना काम कर रहा है, उठ रहा है, बैठ रहा है, बात कर रहा है, सब कुछ एकदम ठीक है, और अचानक से वो जो है अजीब हरकतें करने लगता है. हो सकता है बेहोश हो जाए, जमीन पे गिर जाए, उसको झटके आने लगे, तो ये कुछ उनको ये लगता है कुछ किस्म का दैवीय इंसिडेंट या कोई डिवाइन इंसिडेंट हुआ है शायद इस वजह से, और अब ज्यादा समझ नहीं है, अगर वो किसी डॉक्टर या हेल्थ वर्कर के संपर्क में नहीं आए और उनको मिर्गी के बारे में जो साइंटिफिक बेसिस है उसका किसी ने नहीं बताया है, तो ये उसके बारे में सोच लेना मेरे ख्याल से इस वजह से वो ऐसा सोच लेते हैं, क्योंकि अच्छा भला आदमी अचानक से बेहोश हो गया और फिर कुछ ही मिनटों के बाद, बहुत कम समय के बाद फिर एकदम नॉर्मल हो गया। तो इसको समझ पाना, जब तक कि आप इसके बारे में अगर साइंटिफिकली नहीं जान रहे हैं, so it seems very close to something very strange and maybe spiritual or maybe some intervention from आप कुछ और सोच सकते हैं कि ये लोग बोलते हैं साया आ गया उनके ऊपर इत्यादि। तो इस वजह से मेरे ख्याल से इसके बारे में इतनी भ्रांतियां प्रचलित हैं और जानकारी के कमी के वजह से बहुत सारी गलत धारणाएं भी प्रचलित हैं। तो इससे हम केवल यही समझ सकते हैं कि डॉक्टरों की और हेल्थ वर्कर्स की जिम्मेदारी और बढ़ जाती है कि हम ना केवल अपना समय और अपना प्रयत्न इलाज में लगाएं, बल्कि मिर्गी के बारे में जितनी गलत जानकारी या जो जानकारी की कमी है उसको दूर करने में भी हम उतना ही प्रयत्न करें।
थैंक यू डॉक्टर ममता, यू हैव हाईलाइटेड द इश्यू। आपने बिल्कुल सही बताया कि इस बीमारी के बारे में बहुत सारी भ्रांतियां हैं और ये कई सदियों से चली आ रही है, क्योंकि उस जमाने में शायद हो सकता है कि एपिलेप्सी समझ में नहीं आया लोगों को और वो हिस्टीरिया के साथ मिक्स हो गया। हम इसके बारे में आगे चर्चा करेंगे, लेकिन मैं दिल्ली से ऊपर चला जाता हूँ कोलकाता की तरफ और अमित हल्दर से एक सवाल पूछना चाहता हूँ कि Amit Haldar, is there anything special about epilepsy in your part of the world? Because I think that India is a country with different culture, different religion, different personality all across. And we talked about North and we talk about West. I want to know from you about what is the perception of epilepsy in Northeast?
In eastern part of India, actually the perception also follows the same trend. In the urban areas, probably places around, say, Kolkata or some of the urban centers, people are more aware of the disease and they readily seek medical help. They know that this may be something which is treatable, needs investigation, consultation with a doctor. But the more remote you go, the more is the level of ignorance. And what happens is, in the districts, especially where there are no good medical setups, a lot of people are being treated by quacks. And after I have seen prescriptions where the first visit has been to a proper medical center, has been advised tests by the doctors, and the test they have done a CT scan or an EEG, but after a few months they have discontinued medicine once a breakthrough seizure has occurred, or sometimes even without a breakthrough seizure. So compliance is a major issue. So after a few months, either they feel that these medicines are not working and they are not able to follow up regularly with a neurologist, they stop the medicines. And then they come under the clutches of quacks. Sometimes some village elders start saying that this is some kind of non-medical disease, psychological disease, and all these things get more and more increased. So probably in the cities there has been some improvement, but in the remote areas it's still, in the majority of the cases, especially where the literacy level is low and the disease is still not being properly treated.
Thank you, Dr. Haldar. I think, so we are trying to understand that the country as a whole, do the different religion, different system, but the myths remain same. And so I come to South India, and here is Professor Asha Lata, and I want to know from her, is there anything different perception in South India? And what I'm trying to tell the people that different culture, different food, different habits, yet the disease epilepsy is what is being seen. So Asha Lata, what are your perceptions from South about epilepsy?
Thank you, sir, for that kind invitation and for your personal call as well. So I think I'm supposed to compare the North and the South. And, I think
may not be compared. I'm just saying that, you know, the people should know that whole country may be different, but the disease is one which affects everyone same way. So the culture and what are the myths associated with epilepsy in South India? Your experience, because you are an epilepsy expert.
The myths, I think, are comparatively less, at least in my part, that is Kerala. I don't know whether it's because of the high literacy which the people have, or maybe because of the greater way in which we percolate to the community here. But the misconceptions like somebody was saying about smelling of chapels and asking the patient to hold a key and such false and very untoward things are not that common in South India. But having said that, I think the prevalence is almost the same in North and South. That is what the studies say, that is around 5 to 10 per thousand population are suffering from epilepsy. So as far as prevalence is concerned, the numbers are the same. The treatment gap, that is the number of people who are yet to receive any treatment, is almost the same when you compare the 4 South Indian states as compared to the other parts of the world. But the myths and misconceptions may be a little less as compared to the other parts of the world.
So what inference comes is that literacy makes a difference, and therefore we would request everybody to be literate. The better literacy will remove the myths, and I think it's a valid point which you have brought down. Thank you very much. So we move to Jayanthi back. So Jayanthi, can you tell us what is the age of epilepsy? Is this come only in children?
Actually, epilepsy is just a condition. It's like a symptom, that is seizures over and over again. And that can happen because of any kind of injury to the brain. In 50% of people, you can't even find a clear reason. So when we know that the causes of epilepsy are very wide, and so it is not one disease, it can be because of various reasons. So that is why there is no age barrier when epilepsy can start. Having said that, epilepsy is very common in young children, and many of these children, as they grow older, may outgrow their epilepsy. There is another spike of epilepsy that happens around teenage and adolescence. But when you look at conditions like head injury or infections in the brain, these things can happen to anybody at any time. Tumors in the brain, this can also happen at any time. Strokes are a major other cause for epilepsy. So when somebody has a stroke, which is usually much more common in the older people, much later in life, they can have seizures and epilepsy. So honestly, there is no age that is protected from when epilepsy can start. It can start at any age.
Thank you, Jayanthi. The epilepsy can start any age, but Mamta, क्या आप बता सकती है कौन सी एज में epilepsy ज्यादा हो सकती है, क्यों हो सकती है, क्यों children ज्यादा susceptible है, क्यों elderly ज्यादा susceptible है? Is Mamta there? Seems that Mamta has. So since Mamta is logged out, Amit, can you tell us about this?
He's muted. Amit is muted.
Dr. Amit, you have to unmute yourself.
Yes. Yeah. So in children, especially, there are a lot of inherited causes of the of epilepsy, and secondly, there are some due to actually poor antenatal care. Sometimes we get perinatal injuries of the brain, and they can present with epilepsy in early life. Along with that, there are all the genetic disease, structural disease, and some of the epilepsy syndromes start usually in the first few years of life. This makes the children particularly vulnerable. And in our country, apart from this process, a lot of infectious diseases like viral encephalitis and Japanese bee encephalitis in certain parts of India. Then you have tuberculosis, which not only in children can affect almost all ages of life in our country. So these are important causes of epilepsy which affect the children. So apart from the genetic causes in India, particularly infectious diseases and poor antenatal care or peripartum care leading to brain damage, leading to epilepsy are important causes which make the children especially vulnerable. And a lot of epilepsy starts in this age group.
Wonderful. So you have explained about the age, children, genetic causes, and also the infectious causes. So Ashalata, would you like to highlight something like cysticercosis, how common it is, and what is this, and how one can prevent? So what I'm asking you is two major problems which in India, one is cysticercosis, another is road traffic injury, which are easily one of those preventing causes of epilepsy. So can you highlight on them and what people should do so that they can protect themselves from disease like epilepsy?
Yeah. So first is about neurocysticercosis. But the common man should know that it is a parasitic infection which can affect anyone, and it is caused by a worm which is called tapeworm, and the intermediate host, that is beneath pigs. I think it's called a sewer in Hindi out there. So since this is something which is treatable, as sir was rightly mentioning, the infection can occur in the brain, and it can cause permanent impact of it in the brain, and there can be lesions, or what is known as the this worm deposits something in the brain for the common man to understand it better, and that can cause seizures. And how it can be prevented is by using vegetables which we take from the market, and we have to wash it properly. And although through meat, it's very unlikely to get into the central nervous system, the people who use meat in this part of India or the other few states of India, that should be properly cooked. The most important thing is through the salads and all, it can spread. So when you buy those from the groceries or from the vegetable vendors, it should be properly washed, and the raw ones which carry the eggs of the so-called pig, which harbors this particular organism, can it enter through the intestinal tract and migrate to the brain. So that is one thing. And as we all know, India is very notorious in the broad area of accidents. There are so many road traffic accidents because it's a highly populous country. In a country where 130 million people are living, especially in the urban areas, almost all of us have vehicles, and once hit and run happens, or a road traffic accident happens, it can cause head injury, and sometimes it can cause seizures in the long run. So the road traffic rules have to be laid down in such a way that this can also be prevented to a large extent. So as the third one, which Dr. Halda was mentioning, is tuberculosis. But I think in the last 1 decade or so, that the prevalence of tuberculosis is coming down in a much bigger way because of the big propaganda that is happening in the that both the sides of the both north and south, and because that the National Tuberculosis Program is a very well-run program. Likewise, in cystic cirrhosis also, especially because it causes epilepsy, there should be some more programs that are targeted to make people understand that it's a potentially preventable disease, because I think we as neurologists should be more taking an upper hand in doing so, because this can result in sometimes very bad seizures. So, and this is what I have to comment about it.
Thank you, Asha. Has Mamta joined? Not yet. I think I can't see her yet. So I will wait for Mamta to come and ask her some questions. So meanwhile, we move back to the Jayanthi. Jayanthi, could you tell us, if somebody has epilepsy, how do you diagnose? When a patient comes to you, what are the things tells you that, yes, this is epilepsy?
Yeah, so the most important aspect about epilepsy is the seizures. That is those events that the patient experiences. So when they come to the clinic, we always make sure that they are accompanied by somebody who has actually witnessed the event, because a description from the onlooker is as important. So first and foremost thing is the details about the event that has happened with the patient. So we try to get a detailed description, not only from the patient, because the patient initially may experience some warning symptom. So we first ask the patient whether there was any warning that the patient had. And then sometime along the course of the event, he or she may have become unconscious. So at that time, what happened to the patient, that details have to be taken from the onlooker. So in epilepsy, only tests don't do the job. It is primarily the history taking, as we call it, getting the details about the event. And we may have to get details about multiple events if they have been multiple. The circumstances in which the event happened is also important. For example, the patient may have just had an episode of diarrhea or something like that, and maybe feeling very weak and maybe out and standing, and he may just faint. And in that situation, it may be actually a fainting episode, and it may not be a epileptic fit. So the context in which this happens is very important. What exactly happened is very important. And also after, and how did the person come out of that episode? So if it's a fainting episode, which is what many times an epileptic fit is mistaken for, the person wakes up very promptly and is, recovers very quickly. Whereas if it is an epileptic event, after the shaking or whatever happens, the person may be confused for a much longer period. So here I would also like to emphasize that fits come in many forms. So the typical understanding about a fit is that person behosh ho jata hai, girta hai, jhatke aate hain, muh se jaag nikalti hai.
So we will come back to the various other epileptic attacks, Dr. Jayanthi.
Okay,
so
no problem.
What we got from you is that epilepsy is a interview, investigation, like a policeman or like a CBI person interrogating the people who have seen, because sometimes patients don't remember anything. So that is what is important. So from this, I move on to Amit. So Amit, do you mean to say that what Jayanthi has said, it is only a diagnosis, you have to interview history, that will tell you. That means you mean to say that there is no role for EEG, MRI, or they are important? Amit, can you tell us? Because I'm now confused. I think Jayanthi said only history, interview karo. So now what you have to say, is there any role, or is they important, or they are important in some situations? So Amit, there you are. Unmute yourself.
Yeah, as I think Madam said, that history is very important. It is the cornerstone on the basis of which the diagnosis is made, but we need some investigations where not only we find out whether it's epilepsy or not, secondly, what type of epilepsy. So obviously investigations are complementary to history and clinical examination. One thing I wanted to add here is that in the last say 15-20 years, use of mobile phones, this is helped us a lot in diagnosis, because what used to happen is in our outdoors, we see patients, they are not able to describe the events, and then they bring a relative who is also not able to describe the event. He or she may be an eyewitness. So using the recording the event, if especially it's occurring in repeated fashion fairly frequently, that video of the event can sometimes make the diagnosis very obvious. Next, regarding the investigation, obviously radiological investigation and electroencephalogram are two very important investigative tools, but we should not also forget the routine blood investigations, because what happens is sometimes someone has got diabetes, his sugar comes down, he faints, and he has a brief jerking of one side, and then he is being treated for epilepsy. So blood sugar, serum electrolytes, all these provoke seizures. Actually, they provoke an attack. They may not itself cause epilepsy, but these are common things which we need to rule out. After that,
Fantastic.
Obviously, EEG, electroencephalogram, is the most important diagnostic tool in our hand, and it's because people do not have a clear idea about it. So
Amit will come back to EEG later on.
Yeah, yes.
So we will revert to that. So now I go to Asha, because you also talked about type of epilepsy, and Jayanthi also said it's not necessary that all the time hands and the legs should be stiff. So Asha, Lata, question is, what are the various kind of epilepsy? And now the Mamta has also joined. So you tell us, and then I'll revert to Mamta. Part of it, I will ask her that various kind of epilepsy. So if you could tell about the major attack, and then I can go to the other attack to Mamta. Asha.
Yes. So what people are mostly scared of is what is called a major attack, as rightly said. And what is meant by a major attack, as most of us know, and the common man must have seen at least in movies, that both the hands and legs are shaking, and their head may be turned back on one side, and they might fall down, and this can cause injuries and all. So there is often a misconception that this is the only type of seizure, and that is not correct. Again, it's not a myth, but a misconception. So one should not be under the impression that every other person who has got epilepsy, that is 2 or more seizures, would always have this type of very big seizure, in which this very bad picture you have in mind. About the other type of epilepsy, my colleague will be speaking on, but this type of epilepsy, which to the common man may be even now called as grand mal seizures, it occurs only in a few percentage of people, and that too with good treatment, it can be controlled. So this is what is called the major type of seizure.
जिसको हम बड़ा दौरा भी बोलते हैं, grand mal seizure. So Asha Lata has spoken about what everybody is scared and what we see at platforms or cinema hall or on the road, and everybody come around and join. So Mamta, आपके लिए बड़ा सिंपल सा सवाल है. We were missing you. तो सवाल ये है कि ये इसके अलावा भी और क्या एपिलेप्सी या मिर्गी के दौरे होते हैं, और उनको कैसे आम आदमी को कैसे बताया जाए कि आप इनको पकड़िए और ये मिर्गी के दौरे हो सकते हैं, और आप इनको तुरंत डॉक्टर के पास लेके जाइए, क्योंकि जरूरी नहीं है कि हर एक को हर बार आशा है टोल्ड कि ग्रैंड माल सीजर कुछ ज्यादा परसेंटेज में नहीं होते हैं, 15 से 20% में लोगों में होते हैं. तो ममता भूषण सिंह, जरा इसके ऊपर थोड़ा आप प्रकाश डालिए. Mamta, your voice is not connected, it seems. You will have to re-log in. So we move back to the Jayanthi on this question which she started. So what are the other kind of
डॉक्टर आशा ने जैसे बताया,
okay, got it.
जो है हालांकि वो बहुत खतरनाक हैं, उनमें चोट लगने की संभावना जल्द
Sir, I think ma'am has got logged out. I'll talk
Mamta,
to
your yeah, her network seems to be very poor.
Yes, I'll talk to her, sir. In the meanwhile, you carry on.
So, Jayanthi, I think this question started by you, and you only have to answer it.
Yeah, so Dr. Asha ने हमें बताया कि जो ग्रैंड माल सीजर है, जिसमें we already heard कि वो ड्रामेटिक रहता है, कुछ भयानक भी लगता है, लेकिन ये टाइप की सीजर इज ओनली वन टाइप, और भी टाइप्स रहते हैं. जैसे बच्चों में फ्यू सेकंड्स के लिए बच्चा होश गवा देता है एंड जस्ट पॉजेस, जो वो कर रहा है वो रुक जाता है और आँख की झपकियां लेता है और फिर वो वापस ही गेट्स बैक टू डूइंग व्हाट ही वाज डूइंग बिफोर. तो इसको हम पेटी माल सीजर कहते थे, एब्सेंस सीजर भी कहलाता है, और ये बच्चों में कभी कभार 50 to 100 टाइम्स अ डे भी हो सकता है. लेकिन ये इसकी खूबियत ऐसी है कि काफी बार बच्चे जब स्कूल में या क्लास में रहते हैं, गौर नहीं किया जाता है कि कुछ बच्चे को हो रहा है. दे जस्ट फील दैट वो डे ड्रीमिंग कर रहा है, बच्चे ने ध्यान नहीं दिया, टीचर ने पूछा कुछ और जवाब नहीं दिया तो उसको डांट पड़ती है, बट नोबडी रियलाइजेस कि उसे छोटे छोटे एक्चुअली सीजर्स पड़ रहे हैं. सो दिस ऑफन हैपेंस इन स्कूल गोइंग चिल्ड्रन between the age of say 5 and 10, और इसको हम absence seizures कहते हैं, और it used to earlier be called petit mal epilepsy. But there's also a third type जिसे हम complex partial seizure के नाम से पहचानते थे, और ये adults में भी हो सकती है, जिसमें for a few seconds again आदमी होश गवा देता है, he may not realize कि उसे कुछ हो रहा है, and then ऐसे वो मुंह को चबाता है या हाथों से कुछ हरकतें करता है, and then comes back again after a few, maybe a minute or so. और पूछा जाए तो उसे आइडिया भी नहीं है कि कुछ ऐसे उसने किया था. So this is also a type of partial या focal seizure, हम medical terminology use करते हैं, और in lay language you can just call it absence again, लेकिन ये adults में भी हो सकती है. So I want to emphasize कि हर एक फिट में झटका ही आना है ऐसा नहीं है. तो आप फिर आप कैसे पहचानेंगे जब कोई हरकत रिपीटेडली होती है और उसी टाइप की बिहेवियर फ्यू सेकंड्स के लिए आउट ऑफ द ब्लू होता है और वापस पर्सन रिकवर हो जाता है, इसमें हमें सस्पेक्ट करना है कि शायद ये मिर्गी के दौरे हो सकते हैं. डॉक्टर सूर्या, इज दैट गिविंग क्लैरिटी?
परफेक्ट. आई थिंक आपने जो है एब्सेंट सीजर के बारे में बताया और आपने जो है कॉम्प्लेक्स पार्शियल सीजर के बारे में बताया, तो ये दो तरह के हो गए. लेकिन अभी भी अमित कुछ और बाकी है इसमें. अभी मैडम ने क्या है कि तड़का लगा दिया है, थोड़ा सा नमक डाल दिया है, लेकिन अभी कुछ और बाकी है. तो क्या आप उनके बारे में, जैसे कुछ झटके आते हैं या
मसाला डालेंगे?
So there are another type of seizures which are called myoclonic seizures. The myoclonus, in common language we will probably call it as some kind of jhatka ana. So especially in the young, it starts, say age around 15-16 years, it starts, and usually these attacks are precipitated by sleep deprivation or fasting. So when they stay awake, sometimes in the early morning, they may notice a few jerks, involuntary movements suddenly occurring, especially in the early morning when they are sleep deprived. तो इसको myoclonus बोलते हैं. तो sometimes along with the myoclonus, वो जो generalized seizure, जो grand mal seizure पहले बोलते थे, वो भी होता है. Then we diagnose it as a syndrome. But ये myoclonus को identify करना बहुत difficult होता है, because sometimes the patients may not volunteer the information. So you have to be specific in history. Patients से पूछना पड़ता है whether they are getting sudden abnormal movements when they are brushing their teeth or trying to drink milk or tea. तो वो जो myoclonic seizure वो भी एक टाइप का seizure है. और कभी कभी होता है ये जो फोकल सीजर, मतलब सपोज एक आर्म का जर्किंग और एक लेग का जर्किंग, ऐसे सीजर स्टार्ट होता है. सो इफ दैट फोकल जर्किंग होकर फोकल जर्किंग ही रहता है, मतलब वो हाथ या पाँव में ही कन्फाइंड रहता है. कभी कभी सिर्फ ट्विचिंग ऑफ द एंगल ऑफ द माउथ, मुंह में थोड़ा सा ट्विच होता है, ये इसको फोकल सीजर ही बोलता है. बट समटाइम्स व्हाट हैपेंस इज दैट द फोकल सीजर स्प्रेड्स. तो वो स्प्रेड करके पूरा शरीर में स्प्रेड कर जाता है. देन यू हैव दैट इनवॉलंटरी जर्किंग ऑफ ऑल 4 limbs, and then you get that groaning sound from the mouth. The eyes go to up, and you develop you get frothing from mouth with sometimes loss of consciousness. So इसको बोलता है secondarily generalized. So a focal seizure which has spread to the brain, throughout the brain, and becomes generalized. So to sum up, actually there are focal seizures and there are generalized seizures. Generalized seizures are actually generalized tonic-clonic seizures, which Madam has previously described. Then even absent seizure is a type of generalized seizure where the electrical activity is spread to both sides of the brain. And myoclonic seizures is another important type of generalized seizures where you get jerking and then it can spread. On the other hand, focal seizures can spread or can be limited to one part of the brain. And at times what happens is focal seizure spreads a little bit. So then you get the complex partial seizure where the patient for a brief period of time becomes unaware of the surroundings.
Perfect. So I think you have explained most of the things. So now the food is ready. But Asha Lata, still the desserts are left. So could you explain the other epilepsy which we have not discussed and how do they be diagnosed? What I mean is drop attacks and atonic, tonic seizure, which are part of generalized seizure.
Okay, so the whole idea is to understand the various types in which the epilepsy can present. So I'll just put it up as a few examples. One, of course, which I started off, which is called a grand mal seizures, in which I'm just briefing it up in a minute, where the hands and the legs go shaking and the patient can have a fall. That is one. And as Dr. Amit and Dr. Jayanthi had been mentioning, there can be an arrest of all activities. Arrest means whatever the person was doing stops the activity and keeps staring at you or chewing at you. That can be in children, which is known as absent seizures, or earlier it was called petit mal epilepsy, and now in adults it is called one type of focal seizures. And the third one, as Dr. Amit was mentioning, is a jerk, a sudden shock-like activity which occurs in the hand or even in the face or the whole body. That is a third one. And the fourth one, as Sir was prompting to me, you can have a sudden fall that is called an atonic seizures. For any person to maintain the posture, which is called you have to stand up or sit up and then do something. It is something what is called a muscle tone, which is needed. So when you lose that muscle tone, you suddenly fall to the ground. That is what is called an atonic seizures, and more commonly seen in children. And the other one is what is called a tonic seizures. That is the muscles or the body parts go into some posturing, and the hands or the legs or even the head can go into a particular fixed position, and that is called a tonic seizure. And I don't know whether I should speak about continuous seizures which occurs one by one without the patient regaining.
So we'll come back to status epilepticus later on. We'll go step by step. Thank you very much for explaining this. So Jayanthi, there is a question has come that I sit and I smile and then I I smile and then I just stops for a few seconds. I'm on treatment. So what it is? Can you explain that? Is the smile or laughing has anything to do with seizure?
Yes, there is a very rare kind of a seizure in which a person can kind of start laughing without a reason and may or may not be fully aware of it. So that is what we call in scientific terminology a gelastic seizure. But we have to discuss this in correct context, because it may sometimes also be something behavioral, that is some stress or things like that. Also people may have such behaviors. But yes, can there be a type of seizure, that epileptic seizure, where this happens? Absolutely right. It's called gelastic seizures, and it happens when there is a certain area of the brain. There is a specific condition called hypothalamic hamartoma. Of course, these are all very technical terms, but to answer your limited question, yes, you can have seizures with laughter.
Yeah, so there can be a seizure with laughing, there can be a seizure with reading, and there can be a seizure with music. So all that is possible, but they are rare cases, and rare thing has to be brought to the doctors to see. So we now know that what is epilepsy. We also now know that what are the various kind of epilepsy. But now question comes, Amit, because Mamta is not there. What a person do when he sees somebody getting a major grand mal seizure? What does he do? He watch patiently, or he crowd, or he throw water, or he put shoe, or he put onion, or what does he do?
Yeah.
Can you guide people that, Baba, ye karo,
Yes.
ye mat karo?
I think these are the things which should not be done with, sir, you have already said. So, but unfortunately, in most of the places, this is the thing which is done. So, first thing I think is when someone is having a major seizure, generalized tonic-clonic seizure, is to make the person safe. So by making the person safe does not mean you pour water on his face or try to poke a spoon into the mouth and injure his tongue. So you make the patient lie down, and lie down in a position from where you won't fall, and turn to one side. So this is the most important thing. If you are in a place where you can't give any medicine or something, just make the patient lie down with the body and head turned to one side. If he is wearing something tight, like a necktie or something like that, you should loosen the clothes. If you can place something, a towel or a pillow under the head, that can be of help. And then obviously, if you know that there is some medicine which can be administered, and because then the person cannot take the medicine orally.
So I come back
spring.
to the medicine. So the thing is, there are do's and don'ts, which Amit has said. But most important thing is, don't try and crowd around the patient.
Yes.
Give him a breathing space, and don't try and put
something in the mouth,
spoon or water in the mouth, because he can get into the problem of
lungs.
Water going into the lungs. So very well. So as you rightly pointed out, and Mamta has been here, Mamta has been going around into the rural areas. And are you there, Mamta? Can you hear us now? I just saw her there, and Mamta,
I can hear you, but can you?
Yeah, your voice is broken, Mamta. I think you are bad network. You are.
Can you hear me?
We cannot hear you, Mamta. It says your voice is completely broken. I think you are on a very, very poor network. Can you get a better network? No. So when your network become yellow, green, then no, we can't hear you, Mamta.
Very bad.
Yeah, we can't hear you. Sorry. So, Asha, can you answer this? What is the emergency medicine? As Amit was mentioning, that something you can do. No, Mamta, we just cannot hear you. Your voice is completely broken.
Yeah.
So to take that question, I think emergency management is mostly important in the case of a big seizure. That is what we were mentioning about a grand mal seizure or a major seizure in which somebody falls unconscious. And then there is a condition which is called status, which is one seizure occurring one after another, in which the patient loses the consciousness. That is, they become unconscious in between two seizures. So these are the two emergencies which I can think of. And in case of that seizures which we were describing as focal seizures, in which they have only an arrest of activities, we don't want to take it as an emergency. So first and foremost, as in any case, the airway, that is, the patient should take proper oxygen inside. So the mouth and the nose should be protected, and if something is blocking the airway, that should be taken out. That is the first and foremost thing. And if they are wearing tight clothes, that should be loosened, and they can be put to one side once the seizure gets over. This thing I'm emphasizing because once this hands are jerking, there is a tendency to catch hold of the hands and try to restrict their activity. But it's better, not better. It's not, it should not be done, because there is something called a shoulder dislocation. Shoulders can easily come out because it is something like a ball and socket joint. So when somebody is having a fisted hand or they are having this jerks, don't try to lift them up with the hands or try to put pressure on the hands and all. So the airway should be protected. They should have good ventilation. Their clothes should be loosened, and they should be put on one side if possible. And once the seizure gets over, hardly 2 minutes it takes, either they will go to sleep, or if they are conscious enough, then if there is some food or anything in their mouth, you can clear it off. But during the seizure, better not to put your hands or some spoon or something inside the mouth to prevent the attack from getting the tongue getting cut and all. That is also something which should not be done. If it has to happen, it happens during the early part of the seizure. And if you put your hand or your fingers inside the mouth and all, that can be cut off, and that can cause problems to the caregiver as well. So these are the preliminary steps which has to be done other than the medicines. And then if the seizures come one after another, after doing all these preliminary steps, one has to take the patient to a hospital setting or can resort to medicines.
Thank you very much, Achalata. You have highlighted, and I remember clearly one patient who had a grand mal seizure. He became all right in 2 minutes, but he developed bilateral shoulder fracture, both the neck of humerus, and he needed shoulder replacement on one side and a repair on another side for lifelong, and he remained in the hospital for 3 weeks. So my request to all of you is that don't try and catch the patient. Wonderful. But yet there is an emergency medicine, like particularly in children, the diazepam, which can be used as suppository, or midazolam. So would Jayanthi, you would like to say something about these medicine? Are they useful, or nasal spray? And can this, help the patient when they should be used, how they should be used, or a sublingual midazolam or diazepam nasal spray, which has come now, not available in India, but is available all over other part of the world. So could you just tell us about this emergency rescue medicine for acute seizure?
Yeah, surely. So especially in children, now we have available a nasal spray of a medicine called midazolam. It is available now in various brands. One of them is Insed, the other one is Medistat. So there are a couple of more brands that are Midasip. So these are all from various companies, and they all have the same medication in them called midazolam. So particularly in children, it works quite well, and they are used as a nasal spray. It's not to be given in the mouth. You can give about 4 puffs to 6 puffs to the child, depending on the age and the weight. And always you should talk to your doctor. They will give you the correct dose that has to be administered depending on the age and weight of the child. We also tend to use it in adults, though it has been tested and proved to be very useful in children. In earlier times, we used to use this same midazolam solution as, put it in a syringe and give it inside the mouth. So if you have, midazolam in a bottle, it used to be used before, but since the availability of the spray, this is something you can request your doctor, because sometimes in a long consult that may not be prescribed, may get missed out. So you should request for it and always keep it available. The important thing to know is that this is to be known not by the patient, but by the caregiver. The caregiver should be aware of how to use it. So whoever is there in the house, sometimes the caregiver may keep changing. So that person should be instructed very clearly how to use the spray. So if the child is in school, we always request the parents to inform the teacher or the nurse who is there in the school that how this medicine is to be given, so that they are aware in advance how they have to administer it to the child.
Thank you. Thank you very much. And we move now about the medicine. And Amit, tell us about the first line drug, the common drugs which are used for epilepsy and how they should be used.
Yeah. I think initially till the 1980s, there were only 3 or 4 anti-convulsant medications which were commonly being used. These were phenytoin, phenobarbital, carbamazepine, and sodium valproate. Post 1990, a new generation of anticonvulsant medications have come. So a lot of them have come. I don't want to go into the details of it, but I think still today, at least in generalized epilepsy, probably sodium valproate is a drug of choice, but not in women of childbearing age because of some of the side effects of the drug. So we have to identify the type of epilepsy. This is very important. If it's generalized epilepsy, sodium valproate remains the drug of choice. If it's not general, and if it's a women of childbearing age, we have to think of other broad spectrum anti-convulsant medications. And there's some of the newer medications like levetiracetam and other medications have come up. There are medications which are especially effective in focal epilepsy, carbamazepine among the older drugs, and nowadays oxcarbazepine and even other sodium channel blockers like lacosamide are also available. And there are also some reserve drugs which can be useful in refractory cases, because if we give the right medicines, probably in 60% of the patients, the medicines will control the epilepsy completely. But in some cases, the medicines won't be able to control the epilepsy. There we will need more than one medicines, and they are the mechanism of action.
We'll come back to polytherapy or monotherapy. So you have very correctly mentioned about generalized epilepsy and focal epilepsy and drug of choice. So we move to Asha Lata. Asha, Amit has already put up this question that you have more one drug given, not better. You change over to another drug, not better. So what are these seizures? You also mentioned sometimes respiratory seizure. So how do you deal with them? If somebody has been given 2 medicines, sufficient period of time, still continue to have medicine. So when is that you start thinking of newer drug, add-on drug? How do you decide which drug to be in combination with the primary drug?
Okay. So first and foremost, it is the diagnosis of epilepsy. Now these days there are different syndromes, it is called. That is a group of symptoms and signs put together forms the type of epilepsy. So once you diagnose a type of epilepsy, there is a primary drug which is known to cause respite, total cure, or the majority of seizures will go away in majority of the patients. That is what is called the primary drug. So when you use that drug and that is not going to be beneficial for a particular patient, you think of an alternative drug, either switch on to the second drug. That is the ideal way of doing it, and then taking out the primary drug in a very, very slow manner. And if the second drug is also not effective, then you combine two drugs, and that is what we in a technical terms usually call by the name polytherapy. And that second drug should be chosen in such a way that the first drug acts through a particular way. That is what is called the mechanism by which the drug acts. And the second drug should be acting in a different way. That is, two actions put together, they should produce a much better benefit to the patient. That is the primary, the crux of the philosophy of adding two drugs. Two or more than two drugs also can be there in the scenario. So such patients who requires two or more drugs are generally put under the category of a drug-resistant epilepsy. If they're not responding to two or more drugs for a particular period of time, and this period of time has been defined by various methods, and they are known as drug-resistant epilepsy or drug-refractory epilepsy, etc. And in such patients, we may have to resort to other methods of treatment. So this is what is basically what is known as polytherapy, in which the drugs are combined to see a much better result than what is, which is what we want, but may not happen in all the cases. About 20% of the patients, or close to 20%, may not respond to even 2 or 3 drugs. So they are called drug-resistant epilepsy cases.
Fantastic. So we move.
So should I need to? Yeah.
So I move further on drug-resistant epilepsy, and Jayanthi, what are the other options for drug-resistant epilepsy? What do you do if you have such patients? And I'm sure 10 to 15% patients fall into this category. They are difficult. You try everything, yet they have been getting seizure. So what next?
I think I was muted. Yeah, so firstly, when patients come to you saying that they are on 2 drugs, 3 drugs, still their events are not stopping. Sorry, I come back to the same issue that we first talked to the patient in great detail again, because many times, the events, what they are, we want to establish that they are truly epilepsy events. Because sometimes, such patients also have a lot of other emotional issues and things like that. And some of the events may not be truly epileptic. So you want to ensure that all the events that are happening are genuinely epileptic fits. Secondly, you want to ensure that they are taking the medicines in the correct way as has been prescribed to them, what we call compliance. That means the doses are correct, the doses are not being missed. This is something we like to first ensure is happening. Once we are convinced about both these things, that the medicines are correct for the problem, the doses are correct, the person is taking all the medicines, and still the events are sounding like genuine seizures, then we look at alternative ways of treating the patient. And one of that, in a small group of patients, we can offer brain surgery to control and in fact sometimes even cure the epilepsy. This is not for everybody, but a small subset of patients where medicines are not working. And who are these patients? These are patients where, from the history of talking to the patient and by the tests, as you mentioned, the MRI, we identified that there is one area in the brain where these abnormal currents are coming repeatedly. So if we can sense from the history that it is coming from one area of the brain, then we may consider them for surgery. But we don't do the surgery straight away. We have a whole bunch of tests that we have to perform to prove that really these epileptic currents are coming from one area of the brain. So we try to answer 2 questions before we do the surgery. One is that yes, the epileptic fits are really coming from one area of the brain. And second, that if we can remove this area of the brain by surgery without causing any additional problem to the patient. So both these things we have to establish. And for that is why we do a bunch of tests. And that, in medical terminology, we call this pre-surgical testing. That is all the testing we do before surgery.
Fantastic. So
only if the tests prove that there is one spot, then we offer them surgery with the idea of curing the patient.
So what you say is that you do the pre-surgical evaluation for people which Asalata said, refractory epilepsy, polytherapy. And then if you find something that there is a focus which can be removed on MRI or on investigation, you do the surgery, and you have got a maximum experience of surgery. So I'm sure when it comes from you. So what I want to tell all the people who are here is epilepsy surgery is one of the options in patient who has many attacks a day. Don't get disheartened. Go to the expert like her so that you can be investigated that if you fall into that category and you can be operated for a epilepsy, refractory epilepsy. Amit, is there anything else? Now, there is a patient who has refractory epilepsy, but his MRI is normal. So Jayanti says, I don't find a focus. I can't operate you. Then you do what? Is there anything? Or you say, Baba, theek hai, ghar baitho, dawa khao, aaram karo.
Yeah, I think in most cases that will be the answer. You have to accept that you try to find the right combination of drug, the rational polytherapy. So probably more than one or even sometimes more than two drugs which have different mechanisms of action and can be given as a combination. But there is, in children especially, there is some hope because there is a form of diet called ketogenic diet. So a diet where the fat portion is more than 70% or even up to 80%. It can be used in children as a treatment for epilepsy. This ketogenic diet can sometimes work in non-lesional refractory cases and in some epilepsy syndromes. But this needs proper supervision. Everything what the child will eat has to be measured and has to be done by a trained person because it cannot be managed otherwise.
Wonderful. So ketogenic diet is something which is very important treatment. And is there anything else you have in your pocket?
Yeah, I think there are some newer therapies like vagal nerve stimulator and other things which are which are not available. Yeah,
no,
like TMS.
Vagal nerve stimulation is very much available in India. There are many people who are regularly doing it. So I think Jayanthi has some experience of vagal nerve surgery. Jayanthi, do you have? I know the Hyderabad guys. They have a lot of experience, and in Mumbai we have done a couple of cases. So Jayanthi, could you say something about VNS? What device it is? Is it very, very expensive? I know Paresh has done a couple of cases of ours.
Yeah, so it is when patients has, as you said, that it is an epilepsy where there are multiple foci, multiple areas in the brain from where these abnormal currents are coming. Then you cannot offer surgery. But even in these patients, there is hope because we use vagal nerve stimulator, which is like a pacemaker. It is like how you use a pacemaker for the heart. Similarly, we use a pacemaker for the brain as well. It is in fact implanted exactly like the pacemaker in the chest, but the electrodes don't go into the heart. Here they go into a nerve called the vagus nerve, which is located in the neck. So the exact way the nerve keeps on getting stimulated by the pacemaker at a very low level continuously, and that is programmable. If you use a programming device to program the correct amount of current that has to be given, and that slowly and gradually reduces the number of seizures the person is having. So
Thank you. I think we got it that vagal nerve is another option. But Asha, there is something else now. It's a very hot topic, and India has been right on the top of using this. Our Lord Shiva has been the one who has used it for all these years. Now, people talk about why not cannabinoid, and do you have any experience how it's going to change the prospect, particularly Lennox-Gastaut, or people who have very, very refractory epilepsy, particularly in the children? So what I'm talking to you is about cannabinoid. Do you have an experience and how you see if it comes into India? What are the various ways?
Yeah, I should not give a wrong impression to the people sitting here. So cannabinoids is the active ingredient of what is called the ganja plant. And one should understand that the molecule which we use in for epilepsy is not the same as what is used as when it is used as a recreational agent. So both are entirely different, and it's a different molecule, but the source is the same. So coming back to Sir's question, this had come up in a big way around 5 years back, as in the refractory cases, especially in children. You have something called a cannabidiol, which comes in an oil form, and this oil is said to miraculously bring down the number of seizures. So there are a few other drugs also in the market, not only this one, but we have experience only with 2 people. They have imported from outside, and I think in this forum I should be very truthful. We did not find much of a difference between the drugs which were already there for the patient and this one. So we did not go into that further. And if it comes to the Indian market, we may try on few more patients. But I should be very
well. I think you are very honest. I have been to Queen Square. I was with Helen Cross for some day, and she showed me some 15 to 20 cases, very, very refractory epilepsy, where cannabinoid has worked very well, because it's now marketed in UK. It's available as a prescribed drug. And the child I spoke, and the parents refused to stop the medicine. They said, if we stop, he'll get the seizure. So it has got its own picture. So maybe future, some hope for the people with children who have so many attacks a day and on so many drugs, 4 or 5 drugs. Something can work as magic. Maybe you wait. But Jayanthi, you don't go away. I still have something, there is something is coming, that you put a pacemaker. You talk of pacemaker in the heart, but what about pacemaker in the brain? I know that these are the surgery which are going on, and our audience, they need to know if there's something latest. You are the one who is expert, started surgery. Are you going to get the pacemaker in India? So that it can detect the epilepsy and stop it?
Absolutely. So what happens is, sometimes we identify the area in the brain where the fits are coming from, but it may not be an area that we can operate. Or it may be quite deep in, we don't know the exact location. So we know that the fits are coming from a certain area, but it's not an area which we can operate easily. So in such a situation, what people are doing now is that they put electrodes exactly in the area where the fits are coming from, in that region. That electrode detects when the seizure is coming. And then at that time, you put an extra current to control this seizure. So it's called responsive neurostimulation. So you give extra current to block off this abnormal current in the brain. So it's called a responsive neurostimulation. So you end up putting that pacemaker on the inside this, just under the scalp, and that keeps stimulating the area of the brain only which is abnormal, as and when it fires. So it is still a technique which is not expected to cure the patient of the epilepsy. It is fairly expensive, and it is still in the very early stages being used in the US. So it is not yet available in India, and it requires much more technology to apply. So unlike surgery, where you are more guaranteed of good outcomes, these are all only to control the fits. So since the costs are quite exorbitant, we have not found them very cost effective to use it yet in India.
Thank you, Jayanthi. I just wanted to bring it.
Yeah.
I just wanted it to come to the people, that they should know that there are a lot of things are going on. And so now question comes, Amit, first to you and then to Asha and Jayanthi. Now patient, and this question has actually come here, that I had an epilepsy. I took treatment for 5 years, Tegretol. Now I have no attack. So what do we do next, Amit?
Yeah, actually it depends on the type of epilepsy or the cause of epilepsy. So there are certain epilepsies which, after, if someone remains completely well controlled, no convulsion, the MRI brain is normal, the EEG is normal, after 2-3 years you can gradually take off medicines. Obviously there is a faint chance of recurrence, but if there is a MRI brain shows normalcy and EEG is normal, then the chances of taking of the medicines are high. But on the other hand, you have cases where you have a structural lesion in the brain or you have some scar in the brain. Then even if the person remains convulsion fit free for more than say 5 years, 10 years, there is no guarantee that once you reduce the medicine, the convulsions may not come back. So it has to be on a case-to-case basis. And also there are some epilepsy syndromes, like one of these we had discussed earlier, the childhood absence epilepsy, which is a good syndrome, which most of the cases, after a few years, you can take off medicines. Not in all cases, but in majority of the cases. On the other hand, there is syndromes like a juvenile myoclonic epilepsy, where even after 10 years, 15 years, the convulsions can occur. So unless we find the cause of epilepsy and identify the syndrome type, it cannot be predicted that whether even after 5 years, whether you can take off the medicines or not. So you have to individualize.
Thank you, Kirti. You got your answer. That means you have to go to your doctor, who is the best person to see that when the medicine to be stopped, and he will decide depending on what kind of epilepsy you have and what are the risk factor you have and what is the risk of you getting a re-epileptic attack after stopping the drug. So I hope you got your answer and you are satisfied with that. Now I come to Ashalata. There is one question always remain, and that is epilepsy with women. And is this something entirely different, or they should be managed same way? Very brief, Asha, because now we are on to the last 7 minutes. Yeah.
The treatment per se is not at all different. That is point number one. Point number two, what is different between a man and woman, I think is only the faculty that the women are the ones who bear children, that is the childbirth. So keeping that in mind, from the age when their menstrual cycles start, we tend not to use certain drugs if possible, keeping in mind the fact that when they get married and when they bear children, the children should not get the children, as far as possible, no medicine should be used during the pregnancy period. This is equally applicable in epilepsy as well. So among the around 50 drugs which are available in the market, we should keep in mind that certain drugs, if possible, should be avoided in the reproductive age group. That is very briefly. Otherwise, I don't think there is much of a difference between the treatment aspect as in particular between man and woman. And during the period of delivery also, since the weight of the woman increases and the other factors also can come into play, the gynecologist should work in liaison with the neurologist who is treating and then take it ahead from there. And the children, the last part is the child who is born of a person or a woman with epilepsy. The child also should be particularly taken care of, not during childbirth, but if there are any other issues which come because of the fact that the woman is taking the drug, that also should be addressed even beforehand, even before the child is born. So the reproductive age group should be taken in a bit more serious way. But as far as the treatment is concerned, the various drugs used for epilepsy, the choice remains the same.
Thank you. Jayanthi, is there any particular drug which you think are safe in pregnancy? Because every other day, like yesterday, one lady has come, the gynecologist, she was on oxcarbazepine. Gynecologist told, go to your doctor, I want to stop this drug. So when you are comfortable, when you are not comfortable, I want this answer to go to the audience so that they know that there are drugs which can be taken during the pregnancy, and it is important to take drugs and not to get an attack, and why?
Absolutely, Dr. Surya. I think you hit the nail on two important aspects. One is that you can have a safe pregnancy despite epilepsy. You should continue medicines during the pregnancy as well if you've had active epilepsy. And all this planning should ideally happen before you become pregnant. So if you can follow this, then most of the pregnancies go safe. the delivery can also happen safely. So it should not be a barrier. Epilepsy should not be a barrier to a marriage or childbearing, but needs a little planning and needs systematic surveillance by the neurologist and also by the gynecologist. As you said, the number of safe drugs are during pregnancy have only increased over the last 2 or 3 decades. In fact, we have about 3 or 4 drugs which are quite safe during pregnancy. So you need to talk to your neurologist even as you're getting married. In fact, I bring it up with young girls, even because people don't come for regular follow-up. So this has to be discussed actively with your doctor. If your doctor doesn't bring it up, if you're planning marriage and pregnancy, you need to discuss it with your doctor. And there are certain vitamins we like to give in advance. And you should definitely not abruptly stop medicines when you discover that you're pregnant. So that's extremely important.
Thank you. And not to forget folic acid in a younger woman.
Vitamins. That's what I said. Some vitamins have to be given. Yeah.
Folic acid must be taken. All the people, whether they are getting married or not, please take it. So we are into the last couple of questions, and Amit, as I talked to these 2 ladies about the women, is there anything special about elderly and epilepsy? You think elderly needs to be managed differently? Anybody who is 70, 75, epilepsy?
Yes, elderly persons with epilepsy, they have certain individual issues, different issues. One problem is that most of the anti-seizure medications, they cause a little bit of sleepiness, drowsiness, sometimes a little bit of imbalance. And these elderly people are more prone to develop falls. So while prescribing the anti-seizure medication, one has to be careful and avoid medicines which can aggravate imbalance. Secondly, a lot of these elderly people are on polypharmacy. So they are taking medicines for hypertension, for diabetes, for prostate problem, for COPD. So all these medicines, they interact with each other. So medicines which cause minimal drug interaction has to be prescribed. And they may have compromised renal function or compromised liver function. So the comorbid illnesses also has to be taken into account. So medicines which have less side effects, which cause less falls, which have less impairment, and a lot of these patients have coexistent cognitive impairment or dementia. So drugs which will not aggravate the cognitive problems, which will have less drug interaction. So these things need to be taken into account while prescribing the medicines, especially the comorbidities. Otherwise, again, as the basic treatment remains the same.
Fantastic. So there are certain drugs which has to be given carefully. Not to forget, I think very important thing is elderly people, many of them are having comorbidity, as I said, diabetes, blood pressure, liver problem, asthma. So they are on many other drugs, and one need to check what medicine you are giving has got no issue. Dr. Asha Lata, there is one burning question which has just come in my mind, and I think I need to answer before I close, because it's the right 8 o'clock, and hand over to our chairperson. And the question is, if a patient is, you started an anti-epileptic drug, and if the parents' seizure get better, but the newer thing comes in the sense of behavior abnormality, aggression, and why we should not warn the parents that if something like this happens, this may be because of the drug, and connect back to your doctor rather than be happy about that my child has got no fit. So could you highlight on this very quickly, that what are the drugs which can cause behavior abnormality, aggressive behavior, and they need to be immediately acted upon?
Yeah. So this is a very pertinent question, because this we come across on a daily basis these days, especially with the new generation drugs. So in the earlier group of drugs, only phenobarbital used to cause some side effects like hyperactivity, and I think that was manageable. But with the newer generation, few drugs, I should not say that all of them, but few of them are known to produce significant behavioral issues, including good amount of depression, anxiety, suicidal ideation, patients and even aggressive behavior amounting to homicide, etc. But one should be bearing in mind that persons with epilepsy can also have an associated psychiatric issue, because that is also equally common in the community. So while you start a drug and after that, if it is temporarily associated, because after starting the drug, if somebody is getting a behavioral issue, that could be due to the drug per se. So that should be reported to your doctor immediately. And if it is very significant, then we may have to withdraw that drug. A few of the drugs which I can tell you is, of course, there is one important drug which is used in women, which is called levetiracetam, which is almost replaced sodium valproate. But the problem with the drug is that it can cause significant problems. And a newer drug which is used for focal epilepsy, not for the same as levetiracetam, is brivaracetam. That is the second one. And even with drugs like topiramate, sonisamide, and even clobazam, etc., are few of the drugs which can cause that.
So,
But
Ashalata, we can tell the people in a straight word that if after starting the anti-epileptic drug, even if seizures are controlled, if you find any change in the behavior, go and see your doctor, which he will decide which drug it is.
Exactly.
So we come to the last part. There are so many things which are still not answered, and I can go on and on for another few hours with all of you. And I feel sorry that I missed out on Mamta Bhushan Singh, who has tremendous experience of rural outreach services. But I will ask only one line answer from you. Starting from you, what is your message for Purple Day today to the patient? One line.
Epilepsy should be taken as any other disease, and that is what I just want to say.
Thank you.
I
Amit,
will not
what?
say anything more.
Thank you. So epilepsy is like any other disease. Take it like that. Amit, what is your message?
The message to a person with epilepsy is you try to control the disease rather than disease controlling your life. There's hope.
Fantastic. Control the disease and take over as a master of the tiger. Jayanthi.
Yeah, you can have success despite your seizures. So
fantastic. So don't get disheartened. You can still succeed. Epilepsy cannot stop you, like Jayanthi wrote, and many great. So with that note, I thank you, my dear friends, and I thank you all the speakers, though I may be a little bit harsh because I wanted more number of questions to be answered so that knowledge people, because there is yet another last question that I have epilepsy, so do my child will get epilepsy? Chances are very less unless it is a genetic transfer from your family. So Kirti, you have genetic test available today in India. If you have any doubt about it, go and get it done, genetic test. That will solve your problem and your mind, because you will have a peace of mind that my child will be all right. Thank you very much, Sangeeta Rawat and Chaturbuj, for keeping the patience and sitting patiently. I know you all must be wanting to answer so many of questions, but yet now I give you an opportunity to close the session, and then Chandrasekhar can take over from that.
I think we had excellent discussions, and Nirmal, as usual, covered lots of aspects of epilepsy, and all our panelists answered very well. We missed Mamta for some time, and I think really the people will benefit by clearing their doubts, and their knowledge will increase regarding the understanding of epilepsy. And I also have a message to all the people with epilepsy that come out of the shadows of epilepsy and be bold and face the life with, faith, trust, and good confidence in yourself. Just have a confidence in yourself, and I'm sure you can achieve whatever you want in life in spite of epilepsy. So over to Dr. Meshram. Thank you.
Thank you, Sangeeta. For those who are in Mumbai, I just got up and just checked. The C-Link is purple. So if you are around, have a drive to the C-Link. I just got up and seen the C-Link. It is purple. It is shining purple from my house.
Dr. Surya can see it from his window.
Yeah, I'm too far. Nirmal, you can send us the picture.
So, Chandrasekhar, over to you to close the session, please. Chandrasekhar? So Chandrasekhar is not probably something. So, ladies and gentlemen, good night. Have a wonderful day. And those of whom you are more interested in epilepsy, tomorrow we have another session, API, IAN, Freedom series on epilepsy. And we will have, Mansi, if you could put that poster if you have, so that people can note that, and those who wish to be there, they can join tomorrow at 5 o'clock Indian time. 5 to 7 is the session, and we have wonderful speakers, and we will be talking about epilepsy, and then epilepsy in children, epilepsy in elderly, and epilepsy in women. And I look forward to see you there tomorrow. Good night from India.
Night.
And I hope that you all visit the Worldly Ceiling. It will be purple even tomorrow. So tomorrow evening, also you could run around. Sangeeta, tomorrow is Sunday. Take your car and pay the toll tax and have a look at the...
5 to 7 I have to be online. No, so evening में light आएगा. उसके बाद dinner के लिए जाना पड़ेगा.
Yes, so please go for that. Jayanti, you should also go.
Sure, definitely.
Thank you. Thank you.
Thank you so
Namaste.
much. Thank you for the opportunity.
Thank you, sir.
Thank you. Bye-bye.
Bye.
Bye.